Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach. And this is the latest episode of Dadvice TV Live. Now, you may have noticed my voice is a bit scratchy. My kids picked up a nasty bug at school. It got me. I'm at the end of it, starting to get much better. So I'm going to try not to speak too much and spend most of the time letting my guest host speak. And my guest host is someone that all of you know and love. He is the author of Learn the Facts About Kidney Disease, by far the easiest to understand, the easiest to read, the most comforting book out there about CKD. Please welcome Dr. Stephen Rosansky. Oh, let me turn off the book. There we go. Hey, Doc.
Hey, James, I am so sorry that you've got trouble with your voice box. I will say, just to start out, I know you're not necessarily wanting to talk about what you got, but it is COVID, folks. And I will take this opportunity to tell anyone who has not gotten your first COVID shot that you're still, especially if you're older, you still can die from COVID. COVID is still potentially a fatal illness for older folks. Please get your vaccines. Please, when you get your flu shot this year, I'm going to roll my sleeve up for a flu shot and the COVID vaccine. Please get it. Protect yourself.
Hey,
Okay?
a question about that, Doc. Since I've now got COVID, this is my very first time. I've made it all these years without getting it. How long should I wait before I get the new vaccine that just came out? I was going to go get it at the end of this month.
My suggestion is it depends on your exposure. The problem with all the vaccines, I mean, they got the new one that will hit this virus continues to mutate, continues to baffle people that try to stay ahead of it. But we're doing a pretty good job. We got the right virus, we got the right vaccine. The vaccine will make the illness less worse, okay? You still could get sick like James, but unlikely that you will die from it, and that's the bottom line. Now, for me, I am waiting until probably November, December, because I'm going to be traveling in December and February. The vaccine is not a long-lasting thing in terms of protecting yourself from getting it if the virus is around. It doesn't have, without going into too much detail, the way we would really have to protect ourselves is to have some kind of protective coating on our nose, and there's discussion of having that kind of a vaccine. You stick it in your nose, and that could keep the virus from getting in. But you have at least 2 to 4 weeks, you're in the clear. You got good protection. And then I would go, you want to wait till, that gets you into November. So that's what I would do. I would take it
Okay,
also.
sounds good. I'll let you go ahead and finish introducing yourself.
Yeah, but those of you who are active, involved, there's a lot of COVID out there. The flu shot is available. I would go get both now if you've got a lot of everyday exposure. Okay, I am a retired kidney specialist. I've had the good fortune of meeting James through my book, and getting the wonderful privilege of being on James' show. I think the show is a spectacular show. It gives people the opportunity to speak to professionals and not fall for a lot of what James and I call the woo-woo on the internet. But you'll be glad to know that I am a very skeptical doctor. I look at the research carefully before I decide on what's appropriate for you folks. And I'm going to recommend a supplement tonight. So this is going to be a different show. I generally am not in favor of supplements. Neither is the National Kidney Foundation. And by and large, I would avoid all supplements. The one I discussed today, which is part of our topic, it relates to the topic, I think is one to consider. So my background is I've taken care of kidney patients over 40 years. I still see people in the free clinic. I saw one today. I wrote this book primarily to alleviate your concerns, because there's much too much fear about early stage kidney disease, which is basically stage 3A and 3B, but mostly 3A, which is in the 45 to 60 GFR range, which by and large, and I just talked to one of my close friends about this, who's in the 70-year age range like me, I'm 77, that in the non-capitalist medicine society of Australia, New Zealand, I respect them a lot because they're not all about the money of medicine. And they rightly say that if you're over 70 and you have an EGFR over 45, they don't consider you having CKD. And we have most labs not even reporting GFRs over 60 because they're just so inaccurate. So we'll start out hopefully alleviating some fears. And I also wrote the book because I had a lot of research related to when to start dialysis. And one of my studies was voted the #1 game changer because it showed in nephrology, because it showed that starting your dialysis early at higher levels of kidney function may well be harmful. And anyone who is anywhere near starting dialysis, please read what's in my book, bring it to your physician. Don't let them start you on dialysis too soon. And just for those of you who may actually have seen it, if you saw the Times article, they talked about another study done showing that older folks, it's a shame. A lot of you older folks can avoid ever going on a machine if you can keep that doctor from putting you on it when you don't need to go on it. And they found that these older folks that went on the machine didn't do much, if any, better than those who did not go on the machine before they died. So please, if you can, with your physician, discuss that. So we're talking about one of the major problems for all of us in Western society tonight. And by the way, I have written many articles. I've got over 100 publications. And I am currently writing a book, I told James about this, on things that may affect longevity and healthy life. Okay, and one of the big things about your longevity is hardening of the arteries, or atherosclerosis. And why do they call it so what is atherosclerosis? It's the condition of your arteries, and we all get it. We get it starting when we're kids, and you get this cholesterol on the walls of the arteries. And I don't know, those of you who were on my last time I was on the show, we talked about another important risk factor, which is the blood pressure. But today we're talking about another, and you can clearly benefit by getting your blood pressure to goal, which is 120 to 130, the top number. That can certainly potentially increase your lifespan and your health span. Health span is how long you're healthy. Lifespan is how long you live. And a lot of us are not necessarily healthy throughout the end of our life. But you want to be healthy. You want to do all the lifestyle things we talk about. Tonight we're going to focus on exercise. I can't go through a show without saying exercise. But we're going to focus on the cholesterol. So what happens when you eat this stuff, it's in your blood, it gets in the walls of your arteries. This happens over decades. And what happens is that you got little cells in your blood that eat the cholesterol. They deposit it on the walls, and then it forms a scar and a hard plaque. And it's a yucky looking, hard, yellowish stuff, if any of you have seen the blood vessels on TV or on a post-mortem exam. What are the risk factors? Why am I talking about this on a kidney show? Because anyone who truly has kidney disease, one of the reasons to know you have stage 3, right, which is the 30 to 60 GFR range. And again, I'll repeat this every show, your eGFR is just an estimate. It's not a real number. Don't panic. And those of you who are trying to show you research of GFRs going from 60 to 40, it may have been the same GFR, it's just variation in the results on different testing. So if you've got CKD, it's a risk factor for hardening of the arteries. And that's why I'm bringing it to you tonight. The other risk factors, what are the other risk factors? And I'm not going to quiz James too much tonight I usually do, but I'm gonna give him a break because the poor guy's got trouble with his throat and his upper respiratory, and maybe James, if your cough continues, I'd go ahead and get a chest X-ray. Hopefully, you don't have what they call walking pneumonia. The other risk factors: high blood pressure, diabetes, obesity, but we'll focus on the cholesterol. Now, I'll mention two things. Some of you may have first-degree relatives, father, mother, brother, sister that had a heart attack or a stroke for that matter, and you are at a higher risk. And this is going to go in my book on longevity. Your genes are not your destiny. It's been estimated by the experts that maybe 20% of what happens to you in terms of your health is going to be determined by your genes. That's another discussion. But as we talk about in many of our shows, and most of our shows, adopting a healthy lifestyle is extremely important to help you avoid strokes, heart attacks, limb amputation, angina, all those things related to hardening of the arteries to the brain or to the heart. Now, people ask, well, I've got this in my blood vessels. Can I reverse it? No, you cannot reverse it, and don't believe anybody who says you can reverse it. There's never been any proof that it reverses. Your game is to slow it down, and your game is to use the lifestyle things. And we talked about the blood pressure and cholesterol under control and blood sugar under control. Those things, exercise, good diet, sleeping well, reducing your stress, all of those things will contribute greatly to decreasing your risk of getting a problem that comes from atherosclerosis, the heart attacks, the strokes, and the limb amputations. So what happens with atherosclerosis? Why is it a big deal? Well, that plaque that I told you about on your arteries, and the main arteries that we worry about are your brain arteries and your heart arteries. Heart arteries are called coronary arteries. And the plaque gets on those arteries, and it can get thick enough to close them off. The other way that plaque, that nasty looking stuff on the blood vessels can cause a problem is if a piece breaks off. That's called embolic. A piece breaks off, it can flip onto from the bigger to a smaller blood vessel and block it off. So, like we talked about with blood pressure, you want to get to a goal. For a goal for your blood pressure is around 120 to 130 top number. If you're not at your goal, you need to get back to your clinician and say, hey, doc, I talked to my doctor on this TV show. He's a blood pressure and kidney expert, and he said that there's no reason why I shouldn't be able to get my blood pressure to be at this goal level. Can you either send me to another doctor or maybe you change my medicine, okay? Now, if you haven't been following the cholesterol story real close, and I'll ask James this one quick question. Have you heard about good cholesterol, James? You could just shake your head.
Yes, good cholesterol and bad cholesterol.
Okay. So let me give you the good cholesterol, bad cholesterol story. So the good cholesterol story, and I'll tell you, I was all about the good cholesterol. And I myself used to take something to theoretically raise my good cholesterol. I took it for many years. And, you want to get the good cholesterol up. Why not? If it's supposed to be good cholesterol and it protects you in some way from having these bad outcomes. The good cholesterol is called niacin. It's also called vitamin B3. It's also called nicotinic acid. But unfortunately, we got to get rid of that name, good cholesterol. I would no longer call it not good cholesterol. It is the good cholesterol is still a thing, but theoretically, but the niacin is not a thing anymore. Why is niacin not a thing anymore? Because they finally did a really good study, and they looked at the study where people got the niacin or they got placebo, randomized controlled trial. The best and only way to really prove something works or doesn't work. And guess what? Didn't work. No benefit. No benefit, and maybe some harm. And some of the harms of the drug is I've experienced it. You may get flushing, you may get stomach aches. Some people may get their liver function messed up. They can mess with your blood sugar. And in rare cases, and I unfortunately had one of these in one of my patients, it could lead to muscle breakdown. And that muscle breakdown can actually cause kidney failure. So that's rare. I would, but anyway, the point is, if you're on niacin, no evidence that it's going to benefit you as far as this cholesterol thing. And I don't know that there's any other benefit. Okay. We're going to spend most of our time, a little bit of time on the supplement, but tonight we'll spend most of the time on drugs called statins. Statins. Your cholesterol drugs are called statins, like atorvastatin, like pravastatin. I mean, there's a whole long list, and James will provide you with this in the show notes so you can know if you're on one of these statins. He'll give you that list. And these
I just
drugs,
looked up. I'm on rosuvastatin.
you got it, another one. And look, I just for my own edification looked up if there's any research that says one statin's better than the other. There is no research showing one is better than the other. The only reason to go from one statin to another statin is a good reason if you don't tolerate it. Like some people say, oh, I got muscle aches or I got joint aches. Okay, try another one. And you could try another one because that may be what they call idiosyncratic. It may be because of that particular drug. But if you're not getting your level, and we'll get to the goal level, you need to make sure, like your blood pressure, that your doctor looks like my face is getting out of focus. That
Yeah,
your
but
doctor,
we can still hear you.
okay, that your doctor give you the right dose. And I just had my patient today. I doubled his dose last time I saw him, and he's just where I want him because you can get the cholesterol down if you use the right dose. All right. So there's an enormous amount of evidence to show that getting your cholesterol to your goal level, and I'll tell you what that is in a bit, that it will decrease those bad events, the heart attacks, the strokes, the things you worry about, or needing a bypass operation, having chest pain, having angina. A couple of examples of the proof. I'm just giving you two studies. These are big. One, 20,000 patients, was called the heart protection study. Massive benefit for heart attack, strokes, and need for bypass. Another paper called the cholesterol treatment trials, 170,000 people on the drug. Very good evidence that statins work. They work. So get on it and get to the right dose. What is the right dose and what level of, okay, I didn't go far enough. So HDL was considered the good cholesterol. It still is, and it may have a benefit. LDL is the bad cholesterol. Years ago, we said, hey, if you can get it under 100, you're good. The experts have, and I agree with this totally, have moved the bar down, lower and lower. So you want to get, and if you're a kidney patient, you're a patient who's got a risk, you've already had some kind of heart attack, stroke, or problem related to your blood vessels in your brain or your heart, get it below 60. That's your goal, below 60. And ask your doctor, if it's not there, whether he can change your drug or increase your dose of your drug. Okay, so how do statins work? Well, you don't care how they work, as long as they work, but just to give you a couple of brief things. Cholesterol is made in the liver. Liver is a big factor. It makes all kinds of stuff. And it decreases that little liver factory making cholesterol. But here's something that is key, crucial, very important. So many people say, okay, well, my artery is only 50% closed, or, and this part of my artery is not 70% closed. And it's not just how narrow the artery is from the atherosclerosis, from that cholesterol junk. It's the stability of what's formed. It's called a plaque. It's a bunch of junky stuff on your walls of your blood vessels. And what these statins do is they stabilize that plaque. And that's so important, because even if you're not close to being, having a blood vessel close, you want that plaque to be stable. And that's why these drugs have that added benefit. You could actually get an MI with a small amount of blockage because of that unstable plaque issue. And again, James, we'll go ahead and list statins. There's pravastatin, Pravachol, Crestor, rovastatin, simvastatin, Zocor. I happen to take one that Pfizer made called Lipitor, or atorvastatin. And again, when I started taking it, the goal was under 100. Now it was less than 60. Now, let me just take a drink here.
I think my last labs, my cholesterol was around 70. So
your LDL.
Yeah.
Good.
I think that's where it was. It was higher, and then they put me on some medication.
Good, Jane. Okay. There are now. Your doctor may need a second drug, just like it's very common for people with difficult to control blood pressure to need at least 2 and often 3 or more drugs, like James takes.
A lot more than 3.
Yeah. And so you need to get the right drugs when you have a goal. You have a goal for your blood pressure level. You have a goal for your cholesterol. A couple of drugs that can be used in addition to the statins, PIA, I'm not sure how to pronounce it, and that will decrease the amount of cholesterol. Cholesterol comes from the diet, and some of it's manufactured in the liver. That drug decreases the cholesterol coming in from your foods, from the small intestine. There's another drug that's called a K9 inhibitor. It's a long name. And there's a couple of these, and they help the liver get rid of cholesterol, okay? So there are other drugs besides the statins. And then there's some really old drugs, and these are very cheap, that can, and the way they work is kind of a little bit circular. There's something called bile acids that are important for digestion. And the liver needs these bile acids. And if you give these drugs, you can get the liver to use the cholesterol to make those bile acids. So these drugs are called Questran or cholestyramine, probably never heard of it, and Cholestipol or Cholested. So these are just some of the additional drugs that can help you get your cholesterol, your LDL, to goal level. Now, we're going to move on to the other lipid tests that you get. You get LDL, you get HDL, okay, LDL, bad cholesterol, HDL, theoretically good cholesterol. Then you have another lab test, excuse me, which is called triglycerides. I don't know if you've heard of triglycerides, but triglycerides are just fat. And triglycerides should not be measured if you are not fasting. None of these tests should be measured not fasting. But if you've eaten, triglycerides would be through the roof. So then it's not a valid test. And and it's a very different story than your cholesterol, your LDL. Triglycerides, the only time that most clinicians even think about putting you on medicine for triglycerides is when they're over 500. That's pretty damn high. Why? Because when they get that high, there's a relationship between a real high triglycerides and getting a pretty dangerous problem called pancreatitis. You know, your pancreas is the organ that produces insulin, right?
Yep.
And when that, and of course, a lot of people have heard of the horrible cancer of the pancreas, pancreatic cancer, terrible cancer. But pancreatitis is due to inflammation. The pancreas gets inflamed. You get a sick pancreas. Not a cancer, but it can actually be fatal. So over 500 is when we start thinking about treating it. And the drugs that can get triglycerides down one is called Lopid, and the other is called Tricor. And they are primarily for your triglycerides, but they have a small effect on your LDL. And again, James will give you the names of these drugs. Now I'm going to pause and tell you about omega-3 fatty acids. Okay. I used to take, and I showed James earlier, it's called fish oil. And got it on Amazon. It's about 8 cents a pill. I ordered it personally. And as you know, there is a lot of warning for kidney patients to stay away from supplements because they can actually harm you. And there's good examples of supplements that have harmed kidney patients. And the National Kidney Foundation has a position paper against it. Not against this one, I couldn't imagine. So why am I taking omega-3? And again, no matter what you take, there's correlations. And the only way to prove something would be a randomized controlled trial. And, you know, the statins, lots of randomized controlled trials, but you can't really find very many randomized controlled trials on supplements. But there is evidence that they do good things. They lower the triglycerides, which is a good thing, because triglycerides have some effect, high triglycerides have some effect on atherosclerosis. They can improve your cholesterol levels, as we said, but they do a lot more, theoretically. This is all theoretically. They can potentially lower your blood pressure, which is good. They can reduce your risk of heart disease, which is good. They may actually help reduce your risk of cognitive decline, the thing we all worry about, the Alzheimer's dementia kind of thing. May have some benefit. There's been some evidence that it may improve your mood. There's also some evidence that it may help with joint pain, joint stiffness, by its anti-inflammatory ability. It may also contribute to protecting the back of your eye, the retina, and it may help prevent some of that stuff you've heard about, maybe macular degeneration and dry eyes. And then last but not least, it may keep your skin hydrated. So to me, with all these potential, I'm not saying these are 100% proven, these potential benefits, and just by chance, I still get kidney magazines. And one of the articles in the magazine this month was talking about preventing, and this is in an animal model. They actually have the evidence in an animal model. By using this omega-3 stuff, they induced what they call AKI. James, you want to say, you know what that is? AKI is acute.
Acute kidney injury.
Which means your kidney number may go from a GFR of 60 to a GFR of 30 very quickly, or a GFR of 30 to 15 very quickly. And it's usually temporary. But it can go on to be permanent. There are cases, many cases, where the acute kidney injury leads to a need for dialysis, chronic kidney injury. And surprise, surprise, the omega-3 decreased the amount of scarring and made it less likely that the animal would get chronic renal failure. So there may be some benefit there. I mean, these are not, again, they're not one-to-one, they're not proven, hard evidence, but there's enough association, which I think it's good to do. Now, you
Now,
don't need
Dr.
to.
Rowe, how
Yeah.
much fish oil do you recommend daily?
Yeah, no, these pills are fine. These happen to be uh, uh, 1 gram per serving, which is plenty. If you may be a person that eats, and if you eat salmon, mackerel, sardines, trout, you eat a lot of fish, and you're, eating really healthy, this may be overkill, because you can get it omega-3 in these fatty fish like salmon, mackerel, sardines, trout. I eat salmon probably at least once a week, and I like trout too. You can get it in walnuts. You can get it in spinach. You can get it in Brussels sprouts. I mean, you can get it in tofu. I mean, those of you who are vegan, vegetarian, you possibly can get a good bit of this in your food. You can also get in soybeans, and you can get it in shrimp. But hey, for 8 cents a pill, with some people may not like it. It may have a fish oil taste. If it doesn't give you a problem, I would say it's reasonable to take it. But also try to eat the foods. I mean, I'm all for plant-based diet and eating fish, especially these kind of oily fish. And because this way you can get consistent levels of this omega-3 in your system. Now, talking about hardening of the arteries and cholesterol, I need to give you the meat. How do you know if you're having one of these serious problems? How do you know if you're having a heart attack? And this is crucial for everybody to know the signs of whether you're having a heart attack. I mean, atherosclerosis is behind. We didn't mention how it can affect other arteries in the body because it's less common, much more common in diabetics, that it can affect the arteries to your lower extremities. Those of you who are diabetic or no diabetics, they have lots of problems with blood supply to their toes, to their feet, to their legs, and they may wind up getting amputations. So that's part of the atherosclerosis story. And of course, in another talk, we're going to talk about what I think is overlooked by many people that are trying to educate their audience. It's called a brain attack. Like a heart attack, you not get enough blood to the arteries of your brain. That'll be another discussion.
And that's different than a stroke?
Yeah, brain attack, a stroke. And the reason why they talk about brain attack, and let me take a drink. The reason why we talk about brain attack, and I think it's a great idea, is everybody heard the word heart attack. But and one of the reasons to know if you're having a heart attack is to save your life. How can you save your life? Because if you get to the hospital soon enough, and there's one of these things that are blocking your artery to your heart muscle, and you use one of the techniques called clot busters to get rid of that clogged artery, whatever's clogging it, you can save that muscle. You can save yourself from dying. You can save yourself from bad heart failure. So, and the brain attack idea is the same. If you get to the hospital quickly enough and you're having symptoms of a brain attack, you could save the brain tissue from dying. So that's why, and we'll get into that on another talk. How do you know if you're having a heart attack? What are the symptoms? When should you call 911? They're usually sudden and intense. And some people say it's like an elephant sitting on my chest. I mean, that's classic. But it's not always that way. sometimes it comes on slowly, and it can be getting worse over minutes, and it can go away and come back. It's a pressure. It's a squeezing. The other thing that may happen, and this happened to a friend of mine, it can give you symptoms in your arms and in your hands. This particular friend of mine had tingling in his two fingers, when he would be on his bicycle. That was the only thing. It was recurrent. And exercise is what usually brings on the symptoms, because your heart muscle is not getting enough blood and it's screaming out and it's giving you pain. And it could also be pain in your neck, your back, your jaw, and even your stomach, and shortness of breath. So you're having these symptoms, especially if you're breaking out in a cold sweat, call 911, get checked out, get an EKG. Women are more likely to have some of these atypical signs of a heart attack. So women especially, and they often are overlooked because we figure, well, it's a woman, she's not going to have a heart attack. You're having them just like men. It used to be that in my dad's generation, the men would knock off 40s and 50s, and the woman would never have it. Now I think we're becoming equal opportunity heart attack victims, unfortunately. And again, if you're a woman, you may well have some of these shortness of breath, nausea, vomiting, back pain, jaw pain, instead of the usual kind of elephant on my chest. Now, should you get an EKG every year? I would say if you definitely are a kidney patient, you're one of the people at risk. So that's not unreasonable. If you don't have any risk factors, you don't have high blood pressure, you don't have high cholesterol, you don't have diabetes, you don't have obesity, you don't smoke, you don't have family history, then probably not. So I would recommend for everyone, regardless of whether you have any of those risk factors, put you at a higher risk of getting hardening of the arteries and one of the bad events, baseline. Everybody should at least have a baseline EKG, not necessarily every year. What about the stress test? You folks have heard about getting on a treadmill and seeing if there's evidence that your heart's not getting enough blood supply by looking at your EKGs as you exercise. Should you get stress tests? And it's not like colonoscopy or mammography, where there's good data about how often to get it, at what age you should start getting it. The main people who need the stress test is certainly if you're having any symptoms, if you're having chest pain, you're having shortness of breath with activity, and certainly if you've ever passed out without an explanation, or you're having palpitations, you tell your doctor, and that's a very reasonable situation to go ahead and think about doing stress tests to see if there's evidence that you're not getting enough blood to the heart when you exercise. And again, you don't do a stress test if you're currently having symptoms. You want to go call 911 if you're having symptoms, and we call it rule out MI. Be sure you're not having a heart attack with any of the symptoms that we just described. I'm going to give you good time for questions, and I just got to say a few words about one of the things, and I'm not a cardiologist, so I can't claim to be the expert in the area, but I know a good bit about it, and I've looked at the research on it. Too many people start dialysis when they don't need to. Too many people are getting stents in the arteries of the heart when they don't need to. They're way overused, and the experts claim that 8 out of 10 are placed without a good indication. And it's a tough thing. And again, if your doctor wants to put a stent in, you could question him, especially if you're doing it. If you're coming in with a heart symptoms of a heart attack, but stents could save your life by all means. No question. You don't argue with anybody in that situation. Uh, but let me see if I got my doctor daughter calling me. Let me just okay. goes into my hearing aids. Yeah, if you're getting a heart attack, a stent can save your life. You can use clot busters, you can use stents, and they can theoretically have enormous benefits, save your life. But for most of you, that's not what's happening. You're going to get a coronary angiogram, and they're going to say, well, you got some of these arteries that are blocked. And blocked arteries are very common. And like I said, you don't know which of these arteries, even if they're 20% blocked, if that was going to cause a heart attack versus 70% blocked. In general, we don't even think about, cardiologists are putting a stent in unless your blockage is more than 70%. But the thing is that it's really intended for people who cannot get relief from the symptoms of not getting enough blood to your heart muscle. You get chest pain with exercise, it's not relieved with medicine, or you get chest pain at rest. The reason why a lot of people say, and the studies didn't show it's more beneficial than just medical care, unless you have a situation where medical treatment's not getting rid of the problem. You're still symptomatic. It's because your arteries are long and you're putting a tiny little stent in one particular area of the artery, and that might not be the one that winds up causing the heart attack. And don't be excited to get stents, because then you're going to have to be on long-term blood thinners, which have their own problems. So, there are situations like if you got a heart attack in progress, it could save your life, or if you're having symptoms from blocked arteries, angina, and it's not being treated well, then the stent makes sense. So I'm going to let my buddy here. You're good? I'm going to pick some questions.
I'm doing good.
Okay,
this is working out great with me not speaking too much.
All right. Okay. So someone's talking about, Lisa, stage 4 diet tips. Thank you for the question, Lisa. Back up and talk about diet in general. For most people who want to live long, healthy lives, plant-based diet makes sense. Plant-based diets can be continued even through stage 5 as long as you're getting regular checks of potassium, because plants have a lot of potassium. And with very advanced kidney disease, potassium tends to become more of a problem. And then you may need to adjust. Now, we talked about this many times. I'm not going to give you a long discussion about it. You can look at my talks on protein in the diet. When I wrote my book that James showed you, every other book out there was pushing low protein diets. I think that is a massive mistake. I think that everybody wants to know what can slow decline of kidney function. And there are at least 4 new categories of drugs. The old drugs are the ACEs, the Prils and the ARBs, the TANs, like captopril and losartan. Those have been proven to slow your progression if you've got protein in the urine. And they're expensive drugs. And I'm going to have a talk about when these drugs are and when they're not indicated. And there's a paper coming out in one of our main kidney journals where I discuss that with actually a very well-known textbook writer of kidney disease. But stage 4 diet, plant-based, let's follow up with potassium. A relatively low protein diet. We eat about 100 to 120 grams of protein in this country. 60 to 80 gram protein diet, plant-based, would be what I would recommend for someone stage 4 and a diet. Now, someone says, can take you into kidney failure. I'm not sure what that means. But,
COVID. That was
oh,
at the
okay.
beginning.
Oh, okay. Sorry. Yes. Okay. Not to worry. It's not common. But there are cases, it's rare. Back in the beginning, we had very, very, very sick people, and especially very sick older people. And one of the things that happened before they died is they got kidney failure. It's not a typical thing to worry about, not a typical cause of kidney failure. Sandra wants to know natural things to help stage 4 function. As much as Sandra, I love all the natural things, but I think, as I said, it is absolutely critical to know what your urine protein is and follow your urine protein. If you've got significant urine protein, then you need to be on at least an ACE or an ARB at the maximum dose. You need to be considering one of the SGLT2 drugs. We have to look at our prior discussions about drugs that decrease proteinuria, protein in the urine, and slow progression. Natural things, there is nothing natural other than, there are some natural products that might decrease your stress and might decrease your blood pressure, but don't fall for any of the stuff on the internet that's saying that you can do a cleanse or all other nonsense. It is a waste of time. It is a waste of money. And please do not go on very low protein diets, because that can kill you. That can give you malnutrition. That can result in you having less muscle, having fractures. Not a good idea. And the person who advocates it and has written several books on it will try to sell you supplements, which he sells too, which I think is a big racket. Racket, total nonsense. The only time I would even consider it is if you have high protein in the urine. You're a young person, you tried everything else to slow your progression. That's the only time, and that's rare, that I would consider very low protein. Otherwise, I think a relatively low protein as part of the plan. Somebody's got osteopenia 3A, put my magnesium and vitamin D3. Yeah, none of these things. Okay. 3A, you don't have to worry about any of the things that your doctor's using to treat your thin bones. In general, we used to recommend vitamin D for advanced kidney disease, but you got to be careful with whatever you're using vitamin D or calcium for. Used a lot for treating thin bones, that you don't get high levels of blood calcium, because that could eventually worsen your blood vessel problems, and it can worsen your kidney problems. Someone is saying, Hector, what is it? Why is it that one kidney cannot be leaking, but what happens to one happens to both kidneys? Well, I'm not sure what that means, but okay. If you're talking about leaking protein, that's a good question. And basically, what happens, the way the kidneys work, is that blood comes to both kidneys, unless one side of it, there's two arteries that go to the kidney. And if you get my book, I give you basics on kidney anatomy. You've got, the main blood vessel comes out of your heart, it's the aorta, and there's two renal arteries, and those renal arteries eventually get down to the tiny arteries in your kidney that are called capillaries, and that's what we call glomerular capillaries, and that's what gives you the filtration. But if it happens to one kidney, if one of those kidneys is leaky, it's going to be on both sides. Yeah, I don't know. M is asking about PCSK9 inhibitor. I'm not familiar with them in terms of their safety, so I will admit my ignorance. I have not personally used them. Now, there is, okay, the good question here. M, who's asking it? M is asking about glucose control. It's possible, and it's been debated, that there may be some trouble with your sugar control when you go on statins. Here's the bottom line. The bottom line, and this has been discussed ad nauseum over and over and over again, because there's so many people on statins. The small potential of occasionally having a patient that has a higher sugar that can be controlled with many different mechanisms and drugs is worth that problem. The benefits of statins way outweigh that sugar issue. Okay. And now you want to focus on your LDL. Someone's asking about total cholesterol, LDL, HDL. You want to focus on LDL. I used to focus on both. Let's put it this way. If you've got an HDL, I think it's good news. It's not a bad thing. But I wouldn't focus on, our treatment is directed at the LDL. And we have very good drugs to treat it, and we have a very good goal for getting the LDL where we want it. And someone's got a 99 GFR. Like I said, it's not kidney disease. Anything over 60 should not be reported, in my opinion, because it's an unreliable number. High HDL is not something to worry about. CKD, has it affect memory? There's no direct link, but there certainly is a link between having atherosclerosis into the brain. Hardening of the arteries, of the brain arteries, can give you dementia. And one cause of the dementia due to the hardening of the arteries in the brain is called multi-infarct dementia. That big term means that, infarct is a heart attack. Heart muscle, infarct, myocardial infarction, infarct. You can get the same little tiny things in the brain. So that's often connected to atherosclerosis. Plaque can be stabilized, MS, plaque stability. The only thing, it's debatable whether aspirin does it. That's for another talk. I think our next talk is going to be about baby aspirin. That's another big, at least one of my future talks. But statins can help stabilize the plaque. That's important. Talk about, wish I could talk. GFR went down to 20, it's 29. Okay. So somebody says GFR went to 20. Freaked out. I was at 29 for 7 years. Okay. So Jennifer, I don't know all about your GFR change from 20 to 29. First thing I'd want to know is that 20 related to a bout of AKI? And things that a transient drop in kidney function that can be reversed. Are you on one of these drugs that dropped it, like an NSAID, Motrin? Are you dehydrated? Is your blood pressure too low? Did they start any new medications? It is well known that some of these drugs, the ACEs, the ARBs that I just mentioned, as well as the newer drugs that are used to decrease protein in the urine and slow decline of kidney function, can cause an initial decline. Did you get put on one of those drugs? And by the way, it's generally accepted that over the long haul, that might be an initial decline of up to 30%, but long term, we still think they're good to use. Someone's got an LDL 62, no meds, excellent. As far as diet or drugs, it is just not dependable to think that your diet's going to get your cholesterol where you need it, your bad cholesterol. It's way too complicated. I don't advocate it at all. I think if you've got kidney disease, you've got any risk factor for hardening of the arteries, you've got high blood pressure, you've got family history, all the stuff we discussed, get on the drug and get it to goal level. Your diet should just be part of your overall lifestyle thing, your overall way to try to live as long as you can. So
You have
somebody,
answered a lot tonight.
yeah, yeah, yeah. Anyway, yeah, I think anything that has omega-3 is okay. I found one that I think is reasonable, 8 cents a pill, so that's what I'm taking. So somebody stage 4 on the SGLT2, uh, increasing for sugar. Now, again, SGLT2s, ACEs and ARBs can cause an initial decrease in GFR, and it needs to be followed. But like I said, we're okay with a 30% decline. You got to keep following it. Again, if you're not one of these people that's got protein in the urine, it may not be worth the risk of continuing it. You need, and they're expensive too. So not everybody needs to be on. There's also the weight loss drugs. The GLP-1s may have a benefit for slowing decline. What does recommend? We recommend that you take a total of. Yeah. I'm okay with taking about a gram of this stuff. Yeah, you can eat all the things that I said to raise your omega-3, even with CKD4. Yeah, but again, I mean, unless you're a dialysis patient, we're not going to worry about the phosphorus. I mean, phosphorus is when you got almost no kidney function, and that's another long story, which we don't have the time. And people that are on dialysis are plagued with high phosphorus.
Any concerns if your LDL is low?
No. Malnutrition. I would say if your LDL is low, what's your albumin? Your albumin is a good indicator. It's a protein marker. Your albumin is a good indicator of total body protein. And again, I talked about very low protein diets, very bad prognostic sign of a low albumin. If you're losing a lot of protein in the urine, and in turn you have a low albumin, that could be a bad sign. Okay.
Why don't we get one more in?
Okie dokie. Taking. I don't know anything about Crestor. Thank you, Hector. I will look that up. Whether Crestor is a acute kidney failure. I'll tell you what I know about acute kidney failure. As I said, if you're taking one of those drugs to lower your triglycerides, and you're taking a statin, I personally have seen kidney failure. And the way that works is it causes muscle breakdown. And the muscle tissue breakdown poisons the kidney. But I have not heard about it otherwise. So I think that, are we done, James? Or what?
Yeah, we're done. Thank you so much for not making me talk too much.
Yeah, okay. Well, I'm happy to. Yeah.
All right, I want to thank everyone out there for watching. Please give the video a thumbs up. That helps YouTube recommend it to more and more people. This is great information. It's free, and it's from professionals, not from scammers out there trying to sell you something. Thank you so much, Dr. Rowe, for being here, and I'll see all of you in the next video, and I should be doing much, much better. Bye, everyone.